Welcome back to the Deep Dive. Today we are putting on our educational scrubs, so to speak, and performing a systematic review of the techniques that truly define reconstructive knee surgery.
That's right.
We're going deep into the foundations of meniscal repair, focusing specifically on the arthroscopy-assisted inside-out and outside-in methods.
The classics.
The absolute classics. For anyone working in orthopedics, particularly sports medicine, these are really the fundamental techniques that separate preservation from excision.
It really is the essence of what we do in the knee. I mean, meniscal tears are an extremely common injury, whether we're talking about an elite athlete or, the general population.
Oh, absolutely.
And they are a massive driver of chronic knee disability. Our overarching mission today isn't just to list the steps off a page. It's to analyze why these two classic suture techniques still serve as the gold standard, the workhorses, despite all the convenience offered by newer all-inside devices.
And that why is driven by the long game, isn't it? It's our fundamental surgical imperative, which we see backed by decades and decades of data. It's all about tissue preservation.
Exactly.
We know from these huge long-term series that even a seemingly minor partial meniscectomy has been definitively associated with an increased risk of long-term problems,
Right.
mostly symptomatic osteoarthritis.
Right, compared to a successful repair or even controls.
Every single millimeter of meniscal tissue we can save is a millimeter of load-bearing surface we keep. It literally extends the joint's lifespan.
Absolutely. The decision hierarchy it's crystal clear. If a tear is reparable, repair should be mandatory. Multiple studies consistently show better clinical outcomes, less joint space narrowing years down the line following a successful repair versus removal.
So a partial meniscectomy gives you that short-term relief, but you're potentially mortgaging the patient's future joint health.
You are. Which means when it's appropriate, we have to strive to preserve or restore that functional meniscal tissue. And that means mastering the nuances of these suture techniques. So let's start at the beginning. Let's define exactly what we're looking at when we first scope the knee.
Okay, so you get the camera in. What's the initial constellation of factors you're assessing, specifically to determine reparability? Are you thinking biomechanics, biology, or the patient first?
It's a rapid-fire triage, really. It's all based on presentation, pattern, and location. Clinically, you're immediately stratifying the patient. Is this an acute tear in a young, athletic patient with pristine, healthy tissue?
The ideal scenario.
The ideal scenario. Or is this a chronic or degenerative tear where the tissue quality is friable, less robust? The tissue quality itself dictates our biological expectation for healing. A shredded mop-end edge just won't hold a suture the way a clean, acute vertical tear will.
And the tear patterns themselves are kind of an exercise in identifying structural vulnerability, aren't they?
They absolutely are. We see several classic geometries. The vertical longitudinal tear, which is often the most amenable to repair. Then there's the horizontal cleavage tear, which separates the meniscal layers like a book. Right. The radial tear, which runs perpendicular to those circumferential fibers and is biomechanically just devastating.
It completely disrupts hoop stress.
Completely. Then you have oblique tears, flap tears, the famous bucket handle tears, and of course, complex tears, which are a mix of multiple patterns. We then have to map that pattern to its anatomical location. Is it in the anterior horn, the body, the posterior horn, or a root tear? And of course, medial versus lateral.
Each of those quadrants presenting its own unique surgical and healing challenges.
Exactly.
We've established that the ultimate driver for success isn't just the geometry of the tear, but the biology. And that means we have to talk about the critical concept of meniscal vascularity.
This is the compass. This is what guides our entire treatment plan. The meniscus gets its blood supply primarily from the periphery, from branches of the genicular arteries, so we rely completely on the zonal classification, which really just reflects the density of that blood supply.
And those are the red, 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 white, and white, white zones.
Right. The red zone is the peripheral third, closest to the capsule. This zone is highly vascularized. It has the highest inherent healing potential. These are the tears we celebrate seeing.
That's the one you want to find.
It is. Then you move inward to the red-white zone. That's the central third, where the blood supply diminishes pretty dramatically. Tears here can still be repaired, but they often need some help, some augmentation, maybe trephination or a fibrin clot insertion to introduce the necessary biological factors.
I'm trying to bring the party to the tear.
You're bringing the biology to the repair site, and then you have the white zone, the most central avascular portion. If a tear is entirely contained within the zone, surgical repair is often, to put it politely,
Fighting a losing battle.
It's a losing battle. There are just no circulating repair cells to initiate a healing cascade.
So if the tear at least crosses into that red-white zone, we're basically acting as, what, orthopedic gardeners. We're trying to bring that blood supply, that rich soil, to the tear edges.
That's a great way to put it. We're introducing the biological imperative. If we don't have blood specifically, the undifferentiated mesenchymal cells and healing factors carried in the plasma, the healing cascade cannot initiate, no matter how tight the mechanical fixation is.
So the repair is only as strong as the biology supporting it.
100%.
So turning to the treatment spectrum, the non-operative approach seems reserved strictly for those stable tears that don't have mechanical symptoms, usually the smaller, degenerative, or chronic ones.
Correct. Tears that are minimally symptomatic, especially degenerative tears in older patients without locking or giving way, often respond really well to activity modification, physical therapy focused on quad strengthening, NSAIDs, or sometimes even a cortisone injection to manage that local irritation.
If the knee feels stable and the symptoms are manageable, you stay out of the OR.
You avoid the operating room. But once we cross that line into surgery, knowing the pretty severe long-term consequences of removal, the operative options, partial meniscectomy, repair, or replacement, they all really center on that imperative to repair.
It's the driving force.
It is. We are trying to preserve the shock absorption, the joint congruency, and the secondary stability that the meniscal tissue provides. We know that even small partial meniscectomies, where we're just cleaning up a ragged edge, carry an increased risk of future degeneration.
Right.
Therefore, the majority of our time and technical refinement is dedicated to perfecting these repair techniques, like inside out and outside in. We accept the longer recovery time because the long-term payoff is demonstrably better joint health.
So if the biology is there and the mechanical environment is right, we proceed with repair, which brings us directly to the cheat sheet of success. How do we choose which tiers are actually worth the effort? When you're drafting your operative plan, what are the top 3 predictors that make you feel confident a repair is going to heal successfully?
The list of high-yield scenarios is, thankfully, quite predictable. First, the timeline. Acute tears in young, non-degenerated tissue, ideally repaired within weeks of the injury, have the highest success rates because that biological response is still incredibly robust.
The body is still trying to heal itself.
It is. Second, location. Tears in the red zone, where the meniscal rim separation is minimal, we're talking less than 4 millimeters from the capsule, are the most favorable. And third, the pattern. Vertical longitudinal tears, including bucket handle tears, are the canonical candidates because their fiber alignment allows for optimal restoration of hoop stress when you fix them with a vertical mattress suture.
And the influence of the patient's overall joint stability, I mean, that can't be overstated.
It's immense. It is the single most powerful prognostic indicator. We prefer young patients, of course, but above all, we require a stable knee. We have a mountain of evidence confirming that meniscal repairs performed at the same time as an ACL reconstruction have significantly higher success rates than isolated repair.
And why is that exactly? Is it just the biology from the ACL tear, or is it the mechanics?
It's both. The fluid environment generated by the ACL tear a bloody joint provides excellent biological augmentation. But the ultimate key is the restoration of static and dynamic knee stability. You're minimizing shear forces across that repair site during the critical healing months.
That makes the unstable knee with an isolated meniscal tear an immediate red flag. So contrast those winners with the losers.
Complex degenerative tears. The evidence is clear. These tears with multiple planes and poor tissue quality heal far, far less reliably. They often benefit more from a stable partial meniscectomy, as attempts at repair simply fail to hold. The sutures just pull through the tissue. And beyond that, you have to establish a clear patient contract. Repair requires a significantly increased healing time and adherence to strict post-op protocols. If the patient can't comply or they absolutely need an immediate return to weight-bearing, repair might be contraindicated, even if it's technically possible.
It's a commitment to 8 months of disciplined recovery. Okay, so let's drill down into the territorial indications for our 2 workhorse techniques, inside out versus outside in.
Inside out is our definitive workhorse for the posterior and middle thirds of the meniscus.
And why is that?
Because these segments are deep. They're covered by major neurovascular structures, and they require the robust, high-tension compression that only a suture placed from inside the joint and captured outside can reliably provide. The ideal scenario is that clean vertical longitudinal tear in the red or red-white zone in the back half of the knee. It just yields reproducible, solid fixation.
The posterior horn is the high-stakes territory then. It demands the precision of the inside-out method and the required anatomical exposure that comes with it.
Exactly. We're entering the realm where the posterior neurovascular bundle is directly at risk. You need a physical shield, our retractor, to protect it, and that requires an accessory incision. You simply cannot achieve the necessary tension and depth in the posterior knee with percutaneous devices without having a protective barrier in place.
And the outside-in technique. Where does that technique really shine in comparison?
Outside in has really broadened its indications. It used to be just for anterior tiers, but now it's for pretty much anything in the anterior half of the body. Its principal use remains tiers of the anterior horn or the anterior half of the body.
And why is it better there?
Because those anterior areas are much easier to access percutaneously. The neurovascular structures are less directly posterior and thus less vulnerable to a needle pass from the outside. It's also invaluable in certain specialized settings, like in pediatric or very small knees, where manipulating the larger, rigid cannulas required for inside-out fixation might actually risk damaging the articular cartilage.
So if the tear is anterior, outside-in offers precision and minimizes the surgical morbidity. What's the strict anatomical exclusion for outside-in? Where do you absolutely not use it?
The absolute caveat: do not attempt the outside-in technique for far posterior horn tears. Anatomically, the structures are just too crowded. The trajectory of the spinal needle from the outside, aimed at the posterior meniscal root, dramatically increases the risk of damaging critical structures like the popliteal artery or the tibial nerve.
And the healing rates are worse there with this technique too, right?
They are. Healing rates decrease significantly in that far posterior zone using this trajectory. That terrain is reserved for inside out or now some of the newer all-inside devices.
Okay, let's step into the operating room and detail the inside-out technique. This method demands respect because we're deliberately creating a second surgical field to ensure safety. It's a true synergy between the arthroscopic and the open environments.
It is, and the success hinges on meticulous planning and anatomical identification. The requirement for that accessory incision is non-negotiable. This incision is specifically there to visualize the neurovascular structures, protect them, and capture the sharp needle tips as they exit the joint capsule.
Before placing any sutures, though, we need to optimize the biology. What are the essential preparation steps you're taking inside the joint?
We must induce bleeding. This is our biological augmentation. The standard practice involves synovial abrasion. We use an arthroscopic rasp or a shaver to gently roughen up the tear edges in the adjacent synovium, particularly on the capsular side.
And you can see that happening on the scope.
Oh yeah, you see the little petechial bleeding start. This action promotes peripheral bleeding, encouraging the migration of healing factors and those mesenchymal cells right into the tear. Trephination is another method where we intentionally create small, controlled holes leading into the tear from the synovial side to enhance vascular channels into the more vascular portion. We're trying to wake up the repair potential.
Given that inside out provides the most robust fixation, let's walk through the medial meniscal repair first. The medial side often feels slightly more dangerous because the vital structures are relatively closer to the joint line.
On the medial side, our principal worry is the major neurovascular bundle, the tibial nerve and popliteal vessels, and more superficially, the very vulnerable infrapatellar branch of the saphenous nerve.
Which can cause some really annoying numbness post-op if you irritate it.
Protracted, annoying numbness or pain. Exactly. So our incision placement is critical to setting up our protective shield.
Where are you making that cut?
We make a 3-centimeter longitudinal accessory posteromedial incision. It has to be positioned carefully, just posterior to the medial collateral ligament, the MCL, and we want it centered roughly 1/3 above and 2/3 below the joint line. This specific orientation gives you access to the posteromedial capsule without compromising the primary MCL restraint.
Once you're through the skin and subcutaneous fat, the dissection begins. How do you navigate those superficial nerves?
You proceed deliberately. You identify the pes anserine fascia, which is the fascial layer covering the confluence of the hamstring tendons. You have to split this fascia longitudinally. The key maneuver is retracting the anterior portion forward and the medial hamstrings, the semitendinosus, and gracilis posteriorly.
And that's what exposes the infrapatellar branch of the saphenous nerve.
It exposes it and protects it, keeping it safe from our deeper dissection.
And then you go deep to the capsule itself, where you encounter the medial head of the gastrocnemius.
Correct. You dissect the medial head of the gastroc off the posteromedial capsule. Once you've created that plane, you introduce the crucial piece of equipment, the spoon retractor or a popliteal retractor. This is advanced deep along the capsule and retracted posteriorly.
You've called this the surgeon's steel shield before.
It is. Think of it as a steel shield. It acts as the absolute barrier, protecting the entire posterior neurovascular bundle from the sharp tip of that long, flexible needle as it comes out of the joint. Without confirming its placement, you are flying blind.
That mental image of the steel shield catching the needle tip is invaluable. So with the protection confirmed, we pass the suture. What are the biomechanical specifics of the needle passage?
We use a specialized, long, flexible needle, typically threaded with a 2-0 Orion non-absorbable braided suture, and we pass it through an arthroscopic cannula. The passage has to be sequential, moving from posterior to anterior across the tear. We're aiming to create the gold standard, the vertical mattress suture configuration.
Which means 2 passes for each suture.
2 separate passes, one closer to the meniscal rim and one closer to the central edge of the tear.
And why is that vertical mattress so critical? What makes it better than a simple horizontal stitch?
It provides optimal restoration of the hoop tension function. The vertical orientation compresses the superior or femoral and inferior or tibial surfaces of the tear together. It reduces the tear gap while maximizing the surface area of fixation. The sutures should alternate 3 to 5 millimeters apart on the femoral and tibial surfaces to ensure you get an even distribution of compressive load and optimal reduction of that displaced fragment.
Okay, now for the technical moment that causes the most intraoperative stress. Tying the knot on the medial side. You've described this as the ticking time bomb.
It is the moment of maximum risk if you do it wrong. It is absolutely paramount that these sutures be tied with the knee positioned near full extension, ideally around 20 degrees of flexion.
And why is that so important?
The rationale is simple but critical. If you tie these knots with the knee bent at 90 degrees, the posteromedial capsule is relaxed and shortened. When the patient later extends their knee fully, which they need to do for normal gait, those knots can tether the capsule. That can lead to an intractable loss of full extension or worse.
Suture breaks.
The immense tension generated by the extending capsule can saw right through the suture material, causing an immediate repair failure. This is a non-negotiable step.
The moment you feel that tension when extending the knee, if you tied it too tight in flexion, is truly terrifying. You have to ensure that repair is functional across the entire range of motion, especially in extension.
Precisely. You extend to 20 degrees, secure the knot, and then you confirm full, easy extension. If there's any tethering, you haven't tied it correctly, and you need to redo it.
Okay, shifting over to the lateral meniscal repair. The surgical principles of protection remain, but the critical anatomical structures shift.
Our primary concern laterally is the common peroneal nerve. It courses superficially and posteriorly right around the fibular neck, adjacent to the biceps femoris tendon. We use knee flexion, usually around 45 degrees, which helps displace the neurovascular structures a bit more posteriorly, marginally increasing our safety zone.
The incision for the lateral side is posterolateral, just posterior to the fibular collateral ligament, the LCL, centered over the joint line. What's the operative interval here?
We dissect down to develop the interval between the iliotibial band, or ITB, anteriorly, which gives you a good anterior boundary, and the biceps femoris tendon posteriorly. This is our window to the posterolateral capsule, and you have to visualize the lateral head of the gastrocnemius.
The placement of the retractor for protection is basically the mirror image of the medial side then.
That's right. You elevate the lateral head of the gastroc off the posterolateral capsule. Critically, the spoon or retractor is placed anterior to the LG tendon. Since the common peroneal nerve lies posteriorly and medially relative to our surgical window, the retractor placed anterior to the LG shields the nerve path from the needle tips.
And then it's the same vertical mattress technique.
Same vertical mattress technique. A secondary technical point laterally is just being careful that your suture passes don't inadvertently catch or tether the popliteus tendon or the LCL, which could lead to mechanical impingement or knee stiffness later on.
So whether you're medial or lateral, inside out requires meticulous open dissection to manage the neurovascular risks. But in return, it gives a superior tension-controlled fixation in the most vulnerable segments of the knee.
It's the necessary trade-off. A bit higher surgical morbidity for demonstrably higher fixation strength where we need it most.
Let's transition to the outside-in technique. I always appreciate this one for its relative elegance. It really feels like microsurgery compared to the required exposure for inside out. It's the lighter touch method, perfectly suited for the anterior half of the meniscus, where those large posterior incisions are unnecessary.
It certainly reduces the need for extensive soft tissue dissection and avoids the main trunk nerve risks. The principle is simple. Use a small diameter needle, usually a spinal needle, to pass either the definitive repair suture or a shuttle suture from the skin across the tear and into the joint.
And the gold standard application uses the suture shuttle relay system. This creates the same robust vertical mattress construct we aim for with the inside-out technique, but it's all done percutaneously. Can you describe this process visually for us?
Of course. Step 1 is visualization and precise localization. Inside the joint, you use the arthroscope to brightly transilluminate the skin over the target area of the meniscus. This visual guide ensures you accurately mark the precise entry point on the skin. You want that needle to enter exactly over the meniscal tear, minimizing unnecessary tissue damage externally.
Okay, step 2, the needle pass.
A spinal needle is introduced across the skin, fat, and capsule, aiming to traverse the tear from the outer meniscal rim inward. Arthroscopically, we confirm that the needle tip is piercing the meniscal tear line itself. This confirmation is vital. If you're not crossing the tear, the suture won't reduce it.
Once that's confirmed, you establish the shuttle.
Right. We feed a fine wire, or a strong suture shuttle, through the bore of the spinal needle and advance it into the joint. We then retrieve the loop of that wire shuttle through one of the anterior portals, usually with a small grasper. This establishes the first half of our rail system.
The repair suture itself is then introduced into that system.
Exactly. The actual structural repair suture, often a €2 non-absorbable suture, is passed through that retrieved wire loop. Then, as we withdraw the spinal needle through the skin and pull the wire shuttle back out of the portal, the repair suture is drawn through the meniscus, leaving the suture crossing the tear and entering the joint space. That's one limb complete.
And to create the vertical mattress, we need a second limb, parallel to the first.
A second spinal needle is carefully introduced through a slightly different skin puncture point, placed about 3 to 5 millimeters away from the first entry to establish that optimal vertical mattress configuration. We repeat the whole process. Pass the needle, confirm it crosses the pair, pass a second wire, retrieve that wire through the portal, thread the other end of the repair suture through the second wire loop, and pull it back out.
It sounds intricate, but ultimately gives you the same biomechanically superior vertical construct anteriorly. Once the two suture limbs are successfully passed and are exiting the skin, how do you secure the repair?
This is the beauty of the outside in. We make a tiny external incision, just a few millimeters long, between the two suture exits. We carefully and bluntly develop the plane just between the capsule and the subcutaneous tissue. The two ends of the suture are then tied together, forming a square knot over the capsule.
And tying it externally is what reduces the tear.
The critical point is that tying this knot external to the capsule pulls the torn meniscal fragment snugly back against the vascular rim, reducing the tear under controlled tension. This avoids having any knot material inside the joint that could irritate the cartilage.
Let's discuss some of the technical alternatives. I remember the technique of trying to tie a knot inside the joint and then pulling it back out through the meniscal tissue. That always seemed tricky.
It is tricky. That variant involves passing two suture strands into the joint, tying them into a square knot arthroscopically, and then attempting to pull that bulky knot back out through the meniscal substance and the capsule. Pulling the knot through the meniscus is often difficult and creates a lot of friction. It requires a lot of force, sometimes facilitated by tying a smaller dilator knot first, which essentially acts as a guide to widen the hole before the main knot follows. It's technically challenging and generally less favored than the shuttle relay.
And there's a major warning sign around the mulberry knot. This is a construct we generally discourage due to potential articular damage, right?
Absolutely. The mulberry knot technique is a type of all-inside device predecessor. It involves passing a single suture, tying a series of throws, the mulberry knot on one end outside the joint, and then pulling that knot back to sit against the inner surface of the meniscus, using it as an anchor to reduce the tear.
And what's the problem with that?
The problem is twofold. First, it doesn't achieve the true vertical mattress compression required for maximum stability. Second, and crucially, that knot protrudes into the joint space, directly facing the articular cartilage. Under load, this creates a high risk of chondral abrasion, a mechanical grinding against the hyaline cartilage. which is precisely what we were trying to prevent by repairing the meniscus in the first place.
It's a biomechanically inferior and potentially joint-damaging construct.
Exactly.
Finally, the hybrid approach. For those enormous tears spanning the entire length of the meniscus, blending techniques is often the only viable strategy.
It's the pragmatic solution for the largest lesions. If you have a tear that runs from the posterior horn all the way through to the anterior third, you have to use a combination. You address the difficult, deep posterior portion using the robust fixation of inside out, or maybe a modern all-inside device, and then you use the precision, low-morbidity outside-in technique to handle the anterior extent of the tear.
So you're combining the greatest strengths of both approaches.
You are. This ensures comprehensive stabilization across the entire lesion.
We've established that the ultimate mechanical goal is superior fixation. The inevitable question is, how do these classic suture techniques stack up against the newer, slicker, all-inside devices that claim to simplify the whole repair process?
Biomechanics provides a very clear answer here, even if the clinical outcomes are often similar. Biomechanical testing measures pure mechanical strength, load to failure, and stiffness.
And the consensus from the big meta-analyses strongly supported the classic approach, didn't it?
It did. The key finding was that the traditional suture techniques inside out and outside in demonstrated a significantly higher load to failure and greater stiffness compared to almost all contemporary all-inside techniques. In simple terms, they can withstand far more tension before tearing out or failing. This underscores why we still go through the morbidity of the accessory incision for those high-tension posterior repairs.
So mechanically, the custom-tied suture remains king. And within the suture category, configuration matters immensely.
Absolutely.
Yeah.
We are always aiming for the vertical construct. The testing repeatedly showed that the vertical mattress configuration had substantially better load to failure than any horizontal construct.
And why is that again?
Because the vertical mattress optimally captures the circumferential fibers of the meniscus and, critically, restores the hoop tension. When the knee is loaded, the meniscus tries to widen. The vertical mattress compresses the tear while allowing the meniscal body to resist that outward expansion.
And even the angle of the suture itself plays a role, right? The inclination angle.
Yes, that's a fascinating nuance. Biomechanical analysis showed that vertical mattress sutures with increased inclination angles, meaning they were passed at a steeper, more diagonal angle across the meniscal width, exhibited even higher load to failure. This reinforces the idea that we're not just pulling the tissue together, we are restoring the geometry that allows the meniscus to function as a tension band against tibial expansion during weight bearing.
Okay, let's address the clinical reality. Biomechanical superiority is great, but does that translate into significantly better healing and lower reoperation rates compared to the devices?
That's where the data gets nuanced. Biomechanically strong doesn't necessarily mean biologically better, but it does mean a repair that can withstand slightly higher early loads during that critical 6-week healing window.
So looking at the inside-out technique specifically, what are the outcomes like?
Inside Out has a long track record. Studies confirm good clinical outcomes, high return to sport rates, and demonstrated chondroprotective effects, particularly for those classic vertical longitudinal tears in younger active patients.
But we have to be realistic about failure.
We do. The expected clinical failure rate for inside out repairs still hovers around 17% overall. This isn't a failure of the technique itself, but often a failure of biology or patient compliance.
And the primary complication associated with inside out, linked directly to its required invasive nature, is the higher association with nerve symptoms.
That is the trade-off. The accessory incision, which is required for protection, is also the source of potential morbidity, a higher rate of transient neuropraxia, numbness, or irritation, particularly affecting the infrapatellar branch of the saphenous nerve medially or the common peroneal nerve laterally. While it's usually transient, it's a non-zero risk we have to weigh against the benefit of superior fixation.
The outside-in technique, targeting that anterior, more vascular territory, seems to post slightly better healing statistics. Is that just because of the better blood supply in that zone?
I think so. Studies show outside-in yields excellent healing rates, often reported between 84% and 100%. Long-term clinical outcomes also report success around 77%, with a failure rate noted closer to 12%. Because it targets the anterior half, which often has a better, albeit red-white blood supply than the far posterior segment, the biology is just slightly more favorable for those specific tears.
And we keep coming back to the biggest prognostic factor in all the literature.
Yeah.
The ACL connection.
It's the absolute cornerstone of prognosis. It is an established fact that a meniscal repair performed in conjunction with an ACL reconstruction has a substantially better healing and lower failure rate compared to an isolated repair.
Because the biology and the mechanics.
It's the 1-2 punch: the biological milieu of the bloody joint and the mechanical restoration of knee stability. No amount of suture can compensate for a knee that continuously shears and pivots due to ligamentous instability. The meniscus cannot heal if it's constantly being stressed and strained by an unstable tibia.
Finally, that trickiest of tears, the radial tear, which just demolishes hoop tension. We mentioned it's still controversial.
Radial tears are devastating because they're perpendicular to the load-bearing fibers. While they were traditionally considered difficult, success has been documented using aggressive inside-out techniques, sometimes augmented with a fibrin clot to boost the biology. However, biomechanical studies still lack sufficient data to definitively prove that suture methods are superior to specific all-inside devices designed for radial repair. It remains the area of greatest innovation and clinical uncertainty.
We've stressed that patient compliance is crucial, and the recovery is long, potentially up to 8 months, for a high-level return to sport. We need to explain the why behind the strict initial limitations to our patients. It can't just be, don't bend it.
Absolutely. The first 6 weeks of rehab are all about controlling the mechanical environment to allow biology to take hold. The why is rooted in biomechanics. We know from testing that the stresses applied to a healing meniscus vary drastically with the position of the knee.
So tell me the golden rule regarding knee position and meniscal stress.
The biomechanical studies are very clear on this. Loading the knee in extension actually reduces longitudinal tears. The forces tend to push the tear fragments together, which is exactly what we want.
Right.
Conversely, loading the knee in flexion, especially with any rotational or tibial torsion force, produces stresses that are highly detrimental to the healing meniscus. When you bend the knee past a certain point, the meniscus moves significantly, and that constant shear and motion at the repair site will compromise the sutures and the forming scar tissue.
So our initial phase I, from week 0 to 2, is pure protection. What are the specific marching orders for the patient?
Phase I is all about maximizing rest, controlling swelling and pain, and protecting that repair at all costs. The patient is placed in a hinged knee brace, which is kept strictly locked in full or near full extension at all times. We initiate partial weight bearing with crutches, usually just touchdown or toe touch weight bearing only. And the crucial range of motion restriction is instituted immediately. No active or passive flexion past 90 degrees. In some very conservative protocols, we limit it even further, maybe 45 to 60 degrees.
Why are we so strict on limiting flexion in that initial phase?
Because the posteromedial and posterolateral parts of the meniscus are subject to tremendous motion and excursion with flexion. The deeper the flexion, the greater the displacement force across our suture line. We also focus heavily on maximizing quadriceps tone through isometric exercises during this phase. Strong quads are vital for providing dynamic stability that helps unload the knee during early weight transfer.
Okay, moving into phase 2, weeks 2 to 6. This is often where patients start to get impatient.
This is where we start to carefully test the waters, but we're still prioritizing protection. We maintain the partial weight bearing with crutches, and the brace remains locked for walking to control rotation. We typically hold that flexion restriction at 90 degrees maximum. The focus now shifts to achieving and maintaining full, non-painful extension. Any loss of full extension is a critical problem that has to be immediately addressed, often through gentle prone hangs or specific PT techniques.
Now for the debate. The research comparing accelerated versus conservative protocols after an inside-out repair. Did the added risk from immediate weight bearing translate to higher failure?
Surprisingly, no, not significantly. Studies comparing accelerated protocols where patients were allowed immediate full weight bearing against the traditional conservative protocols that restricted weight bearing and ROM for 6 weeks, they showed comparable outcomes.
What were the key findings of that comparison?
The consensus was striking. There was no statistically significant difference in clinical failure rates between the two groups. Failure rates ranged similarly between 9% and 19% in both the accelerated and the conservative cohorts. The accelerated protocols did achieve a faster initial return to full range of motion, which is a big patient satisfaction metric, but the final long-term ROM wasn't different.
So that data gives us confidence that if the repair is mechanically solid, we can afford to be slightly more aggressive with weight bearing than we previously thought.
Exactly.
So synthesizing all this data, what does our practical standard protocol look like? as we move past that critical initial 6-week period?
The standard practice is a partial weight-bearing approach crutches, locked brace for the first 6 weeks. At the 6-week mark, which signifies the end of the initial biologic healing phase, we hit our milestone. If the patient has adequate quadriceps tone, meaning they can do a straight leg raise without an extensor leg, and they're walking without a noticeable limp, we allow the brace to be removed and permit complete full weight bearing.
And the goal for restoring flexion post 6 weeks?
After the first month, the goal is progressive knee flexion, aiming for complete, unrestricted motion by the end of the 3rd month. Phase 3, which is months 3 to 6, focuses on low-impact cardio and strength training, carefully increasing the load. Return to sport, which is high-impact activity, is generally delayed until months 6 to 8, and it's predicated on achieving symmetric strength and the ability to perform complex plyometric movements without pain or effusion.
We have to emphasize the crucial exception here, the radial tear rehabilitation caveat. Why do these perpendicular tears demand such extreme caution?
Because the radial tear interrupts the meniscal hoop stress mechanism entirely. Until that defect heals, the tissue is highly vulnerable to compressive and shear forces. For radial tears, the rehabilitation must not be accelerated.
No exceptions.
No exceptions. The patient is restricted to touchdown weight bearing, often for a prolonged period of 2 to 4 weeks, with the brace strictly locked in full extension. We advance weight bearing and motion significantly more cautiously only after those first 4 weeks to prevent catastrophic failure of the repair under load. That distinction is paramount for protecting this highly vulnerable geometry.
We've completed a really comprehensive surgical review here, moving from the initial biological assessment all the way to the final critical stages of recovery. To reiterate our core surgical takeaways, preservation is the goal. It's driven by the desire to mitigate the long-term risk of osteoarthritis post-meniscectomy.
And the inside-out vertical mattress suture remains the technical gold standard for robust, high-tension repairs in the posterior and middle thirds. We have to always remember the anatomical requirements, the accessory incision, and the use of the retractor as that steel shield to protect the infrapatellar branch of the saphenous nerve medially and the common peroneal nerve laterally.
And the outside-in technique provides the essential, less invasive solution for the anterior half, often blended into a hybrid approach for those massive panmeniscal tears. Biomechanically, while all inside devices offer convenience, the classic suture techniques still provide superior stiffness and load to failure.
And finally, rehabilitation must always respect the biomechanics of healing. We can leverage data allowing for accelerated protocols for stable tears, but we maintain strict limitations against deep flexion and rotation, particularly in the early weeks, and radial tears. They require specialized conservative restriction due to their impact on hoop stress function.
As we wrap up this deep dive, let's return to that central theme of stability. We established unequivocally that the ultimate success of the meniscal repair hinges significantly on concurrent ligamentous stability, noting the dramatic benefits seen with a concomitant ACL reconstruction. This raises a crucial question for the thousands of patients who present with an isolated meniscal tear in a knee that, while not acutely ACL deficient, might have subtle chronic instability. Given that the literature shows residual ligamentous instability is highly detrimental to long-term healing, what level of non-operative bracing, proprioceptive training, or dynamic stability work must precede or follow an isolated meniscal repair to ensure we achieve the best possible long-term result, even in the absence of an acute ACL tear?
It's the difference between merely fixing the tissue and fixing the entire environment, something for you to consider as you review your next case plan and work with your physical therapy team. Thank you for joining us for this deep dive.